Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about a targeted approach to the treatment of non-segmental vitiligo. As our moderator this evening, we have Dr. Leon Kircik, who is president of the International Dermatology Education Foundation, clinical professor of dermatology at Icahn School of Medicine at Mount Sinai, New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, derm research, and skin sciences. As our presenter this evening, we have Dr. Brett King, who is Associate Professor of Dermatology at Yale School of Medicine in New Haven, Connecticut. We'd like to thank our supporter, Incyte Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a survey link will be emailed to you. We would greatly appreciate it if you could fill it in and send it back to us. Again, if you want to submit questions using the question chat pane on the right-hand side of your screen, and we will take questions, if time permitting, at the end of the webinar. So without further ado, I am going to pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone. Thank you for joining us. I am welcome to another series of International Dermatology Education Foundation educational series. As you may know, International Dermatology Education Foundation is a non-profit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. Having said that, we have done quite a few programs, both in North America, in Canada, as well as in Europe, South America, and Southeast Asia. We have done several programs, as you can see here, in our past programs. Tonight, however, we are very happy and very proud to have one of the rising stars in dermatology, a good friend of mine, Dr. Brett King. Dr. King is an associate professor of dermatology at Yale School of Medicine, and he's going to tell us all about a new medication, the first and only treatment option that we have actually approved by FDA, Opzelura, for non-segmental vitiligo. Brett, take the floor. Welcome.
All right. Thank you so much, Leon. And it is a pleasure to be here with all of you. Thank you so much for taking time out of your busy days or nights to be here to learn about Opzelura, which, as Leon said, is the first and only FDA-approved topical treatment for non-segmental vitiligo in adult and pediatric patients, 12 years of age and older. And I think, you know, I don't want anybody to think I'm reading from the slide. That's a really important thing for us to understand. The first and only FDA-approved topical. This is hugely important to us. Let's see. Good. All right. Sorry about that. It'll take me a second to get used to the slides. So on. Okay, we got it now. So just a few bits of housekeeping at the start. This is a promotional presentation and it's sponsored by Incyte. I'm speaking on behalf of and I'm being compensated by Incyte. But just so everybody knows, everything that we're going to review tonight is consistent with FDA regulations, and that's really important. So again, we mentioned this already, Opzelura is indicated for the topical treatment of non-segmental vitiligo in adult and pediatric patients 12 years of age and older. It is for topical short-term and non-continuous chronic treatment of mild to moderate atopic dermatitis. And hopefully everybody on the call is aware of that, right? It was a little bit over a year ago that it was approved for mild to moderate atopic dermatitis. But again, the indication for vitiligo is more recent, happening just in July of this year. My goal is that at the end of our time together, everybody on this call feels like they have great confidence in their understanding of Opzelura for the treatment of vitiligo. And that starts, that understanding, that confidence begins with the boxed warning. We have to have context for it. We all should be aware that there is a boxed warning with headers of mortality, infection, blood clots, major adverse cardiovascular events, and malignancy. And we can talk about this if anybody wants to, but we need to understand the context that much of the label is born of studies of another oral JAK inhibitor in the treatment of patients with rheumatoid arthritis. Okay, so the disease. So vitiligo is an autoimmune disease, an inflammatory disease. And we know, right, that there are several clues about this. One is, right, that comorbid, say, autoimmune thyroid disease is not uncommon in these patients. There's almost certainly a genetic predisposition that these patients have. And then there's a trigger. And this is not perfectly clear. There are many reported triggers. Many of those are listed here: sunburn, physical, skin trauma, also psychological stress. And again, some of these things are uncertain, but again, probably a genetic predisposition combined with a trigger. And now here, this is the, right, we talk about pigmentary disorders. Vitiligo is for sure the most common depigmenting skin condition there is worldwide. And it affects, here the estimates are, quite variable, but probably at least 1% of the population, which means that a lot of people are affected. We see a lot of vitiligo in our clinics. Think about psoriasis. It affects 3% of the population. Vitiligo, 1%, it's not far off. Think about how many treatments we have for the treatment of psoriasis. And now just this very first one for the treatment or the ability to repigment vitiligo. Hugely important to us to understand. So now vitiligo, the way we think about it, we think of there being non-segmental vitiligo, which in the diagram on the right half of the screen is shown in the, some different ways to think about it, being vulgaris, acrofacial for sure, right? We know that this is a disease that loves the feet, the hands, the wrists, the knees, the genitalia, the perioral region, the periocular region. Of course, it can be very limited in extent. It can be very extensive. And then, of course, there's segmental vitiligo, right? Where, typically unilateral disease involving one location, but sometimes a couple of locations. Now here, really important, right? We must not be dismissive of this disease. Patients have many reasons, often deeply personal, for why this disease affects them. Hopefully for this audience, we just understand it instinctively, intuitively. This is a disease that affects people, right? To have white patches on your face, to have white patches on your hands, highly visible areas that the world sees, affects our experience, affects people's experiences with those around them, affects their experiences with the world. And so we're not going to discount this disease. We're going to take it seriously. And then here, just recognize that there is differences across a single person in the amount of pigmentation across different body sites, but also really, really important, there are areas that are more likely to repigment with treatment, and then there are areas that are very unlikely to repigment with treatment, or much less likely. So we think of areas with a high density of hair follicles. So now think about the face in particular, high density of hair follicles and also exposure to ambient light, right? Very high propensity or capacity to repigment. And then at the opposite extreme, you have areas of the body where there are essentially absent hair follicles. Think distal fingers, genitalia, lips, these areas of palms and soles of the hands and the feet, very, very unlikely to repigment. And then of course you have everything in between. But really important to understand this, right, as we think about counseling our patients about treatment and where we can expect them to get and on what time scale we can expect them to get there. So these are just some quotes, I think, very powerful, right? We can look at, data all day long for, studies of health-related quality of life, having patients fill out questionnaires and looking at that data, or you can just listen to patients and say, what is life like with vitiligo? And you hear, the things on the screen. My mother, she's Caucasian, but she went completely white. It was quite a challenge for her to live. Challenge for her to live all that time turning white. Again, these are somebody's words, right? We're not going to question somebody's experience. So now here, let's think about treatment options for the disease. Here, there's not a whole lot. Topical corticosteroids, topical calcineurin inhibitors. And then we have oral corticosteroids reserved here, really important, reserved for trying to arrest rapidly progressive disease, right? So not really, we don't use oral corticosteroids to repigment. It's really important to recognize what we're using what here for. Narrowband ultraviolet B phototherapy, right? So now we think about repigmentation, and again, kind of the goal of topical corticosteroids or topical calcineurin inhibitors. And then surgical therapy, where we take melanocytes from one place and put them somewhere else, typically reserved for non-segmental vitiligo, which again is not what we're here to talk about today. Here we're talking about the vast majority of patients with vitiligo, which is non-segmental vitiligo, not segmental vitiligo. So now here, key takeaways. What have we talked about? Autoimmune disease, right? A lot of data to support that. There are many factors that influence a patient's decision, but right, we all, again, this group of people on the phone right now, we don't even need to know somebody's reason for wanting, because we've spoken to so many patients with this disease. We understand that this is hard, right? Hard to bear this every day. And again, we're going to recognize that there's a myriad responses possible for repigmentation as we move from the face to, say, the fingertips or the toes, and the areas of leukotrichia, areas where there used to be black hair, but now is predominantly white hair. Those vitiligo affected areas are not likely to repigment because the capacity to repigment is in the hair follicle, because that's the home to melanocyte reservoir. And if there's no melanocyte reservoir, meaning the hair is white, we have very little likelihood of repigmentation. All right, so now the mechanism of disease and Opzelura, mechanism of action. This is really fun because we're going to marry Opzelura mechanism of action with the mechanism of disease. This isn't a, oh, take my word for it, this works, it's great. No, we're actually going to very deliberately bring Opzelura to this disease. So the inflammatory response, remember we said autoimmunity, right? So T cells drive depigmentation in vitiligo. So here we see keratinocytes, we see melanocytes associated with them in the basal layer. There's some triggering event or other reason why this starts. We get immune cell activation or recruitment. So you see down here, activated T cells. Activated T cells secrete interferon gamma, an important cytokine driving this disease. The keratinocytes, in turn, in response to interferon gamma, secrete CXCL9 and CXCL10. These are simply chemical signals, chemokines that signal and recruit more T cells. And so you get this feedback loop leading to increased inflammation and ultimately destruction of melanocytes, as shown here, right? Destruction of melanocytes equals depigmentation. And so, this is like the story's building. This is getting exciting. So we have this feedback loop over here on the left, and what's happening is sort of shown and kind of blown up on the right, where again, interferon gamma has a receptor on keratinocytes, and interferon gamma signals through a pathway called the JAK-STAT pathway. So interferon gamma binds its receptor on the cell surface that activates JAK proteins. JAK proteins activate STAT proteins. STAT proteins migrate to the nucleus where gene transcription happens and disease follows, which in this case means CXCL9 and CXCL10 are made, right? And those were the chemokines that recruited T cells. Increased T cells mean this cycle perpetuates. We have melanocyte destruction and a white patch ensues. So really cool. It's all, that's the story right there. We want to interrupt that story. We want to interrupt interferon gamma ever messaging the nucleus. Because if we interrupt that messaging, conceptually anyways, disease goes away. And so what happens when we apply Opzelura, which is a JAK inhibitor, what do? We interrupt the signaling, the messaging from interferon gamma to inside the cell. When we interrupt that message, again, we block this loop of activity and inflammation goes away, and we should see repigmentation if the model works as we think it does. All right. Okay. This is really important. Oh, there are just a few key things here that are just so important for us to take away. Repigmentation takes time. Everybody, please hear me. Repigmentation takes time. And this is key, right? We almost have attention deficit disorder in dermatology, right? Because the biologics in psoriasis have almost trained us to think that everything gets better tomorrow, right? We give a biologic today, 4 weeks later, people are better. We use a biologic or use some of the new oral medications for the treatment of atopic dermatitis. People are better in 4 weeks. Itch goes away. In fact, if you've seen the data for Opzelura in mild to moderate AD, itch goes away in hours. Repigmentation takes time. Think back. Well, don't think back. Here's the graphic in front of you. depigmentation. We cannot create new pigmentation throughout the entire epidermis tomorrow. It's not possible. It takes weeks and months. Really, really important. It takes time. Think about what we're trying to do. We're trying to recruit, right? We have to halt inflammation, then melanocytes have to repopulate depigmented skin, and then you have to, right, stack that up throughout the epidermis in order to get even skin tone again, or even skin color. It takes time. All right, now let's talk about Opzelura. So we're going to talk about 2 identical phase 3 clinical trials. We want that, we insist on that, right? We want to see 2 clinical trials. We want to see similar results between 2 clinical trials to know that right, have confidence in what we're talking about, have confidence in the data that we're looking at. So here we're looking at a 24-week double-blind clinical trial, Opzelura BID, really important, BID, not QD, versus vehicle at week 24, then open label extension out to the end of study over another 28 weeks. So we're looking at a year. Eligibility on the left here, the critical thing is 12 years of age and up. Really important, 12 years of age and up. And again, non-segmental vitiligo here. We're not talking about segmental vitiligo. Oh, and just one more thing, actually. Let me jump back 1 slide. Just that last bullet in eligibility. Patients with complete leukotrichia within any facial lesion were excluded. Okay, so remember I said when you look at a vitiligo patch and somebody otherwise has pigmented hair, but in the vitiligo patch it's almost all white hair, can't repigment. It's not going to repigment because the melanocyte reservoir is in the hair follicle. A white hair says the melanocyte reservoir is gone. Okay, so keep that in mind. It's really important. This means that we can't evaluate patients with vitiligo from the door, right? Which I think is we all kind of have that idea. We can't, you have to get up close. You really have to examine these patients. Okay, so now the endpoints here, we're going to look at an FAAD 75, so 75% improvement in facial vitiligo. And then we're going to look at, and that's at week 24. We're going to look at data out at week 52 as well. And we're also for facial VASI 75. And then we're also going to look at 75% improvement in T-VASI. So total body of vitiligo involvement, looking at 75% improvement in that over 52 weeks. And then there's some key secondary endpoints. We'll talk about these. So here, patient demographics, patient characteristics. These are our patients. Age, 40, 39, right? Female, male, about even. White, okay, we might have asked for more, Black, Asian participants, but look down below at skin phototype, and look, skin phototype 5 and 6. Oh, look, we got 5.5, 7.8, 2.9, 1.2. So again, and then if we look at skin phototype 4 through 6, all of a sudden we've got 25% of patients, and so that's good. So we have pigment represented reasonably well, and then baseline FAAD, baseline T-VASI, right? So you see that baseline FAAD 1. So 1, the surface of an entire hand, right? That's the mean FAAD. So take that, put it on a face. It's a lot of facial involvement. And really important here, duration of disease. Well, median duration, 11 years, 13 years. Woof, right? Long time. And that's important because it tells us that that doesn't inform whether or not somebody can respond. Really, somebody comes in, they say, oh yeah, I've been like this for 20 years. You look, you don't see a preponderance of white hairs. Oh, doesn't matter, it's been 20 years. They can respond, really important. Do not be discouraged and do not discourage patients over that fact. And then you see stable versus progressive disease. Again, 75% stable, a quarter progressive. Again, useful to know. All right, so now FAAD responses at week 24. Okay, so remember, 24-week endpoint, and then we're going to see data out over a year. But let's just start with week 24, so 6 months. This is important. How many of us have given somebody a tube of pimecrolimus, tacrolimus, and said, oh, come back in 8 weeks? 8 weeks. Look at this data. The highest, I would argue, the highest quality data that we have, the highest quality data there is in vitiligo, right? Hundreds of patients treated systematically. It takes time. That was the slide about time to repigmentation. 6 months, what do we see? In the green highlighted bar graphs, we see 30% of patients succeeding as measured by 75% improvement in FAAD. Okay, at week 24, at 6 months. Really important. This takes time. This means that we have to talk to patients, right? We're going to give them medicine and we're going to say, we are going to think about progress over 6 months, not over 1 month, not over 2 months, not over 3 months. Again, this comes back to our ADD. 6 months at least. And then look, FAAD 90. Totally respectable. 15% of patients nearly completely repigmenting their facial vitiligo over 6 months. But again, 15% is not 50. And so if we do not counsel our patients, if we do not have a conversation with them to help them to set appropriate expectations, we're going to lose them, and unnecessarily, right? We just have to get them into this idea. This takes time. There is no instant fix here. And just some examples. Baseline, look at the cheek, look at the forehead on the other side, the eyelids, week 12, dramatic decrease, week 24, again, we see stable, right? So there was a dramatic improvement and then stability. So this is rapid, right? I mean, this is what we would love to see all the time. But again, it's rapid. Now FAAD 90 at week 24. So here again, holy cow, look at this, right? Baseline, week 12, quite dramatic, week 24, continued improvement. Again, I love these images because they tell us what's possible, but I really encourage everybody, think back to the data. We're thinking 24 weeks or longer, right? We don't want to tell people, oh, in 12 weeks, you're gonna be 75% better. No. If that happens, great. We know that patient's gonna buy in, but it doesn't have to be that way. It can often be much slower. And then here, FAAD 50. So 50% repigmentation at week 24, just another example. All right, so now here, what does data look like over 52 weeks? So the bar graphs that we just looked at were 24 weeks. Now the patients roll into open label extension. Now everybody's getting Opzelura BID for 28 weeks. And what do we see? So the green, the solid line rather, this is awesome. We go from 30% of patients to 50% of patients achieving an FAAD 75. Again, what's the big message there? This takes time. This is not psoriasis. This is not atopic dermatitis. This takes time. And what do you see in the dotted line? We'd love to see this, right? We take the patients who are on placebo or on vehicle control over 24 weeks, we flip them over to Opzelura BID, and what do we see? Oh, lo and behold, they repigment, which is what we would expect. So now here, again, FAAD 75 at week 52. So you see baseline at week 24, there's 44% change. So improvement, slow, and then over another 28 weeks, much better. So now percentage of subjects achieving FAAD 90 during 52 weeks of treatment. So remember the bar graphs at 24 weeks, 15% of patients achieved an FAAD 90 or a 90% improvement in their baseline facial vitiligo. So now what happens when we add 28 weeks to that and we go out to a year of Opzelura twice a day? Really important here, twice a day. We want, right, I'm gonna reinforce this a lot. Patient counseling. It's one of the things that we've really been remiss about in the care of our patients with vitiligo forever. That's going to change now. That story is going to change because we now know how to do this. This is twice a day. We do not tell patients once a day because the effect is not the same. Twice a day. And what happens though, over another 28 weeks out to a year, we now have a third of patients, approximately a third of patients, achieving FAAD 90, 90% improvement, near complete repigmentation of facial vitiligo. And again, right, when we flip those placebo patients over to treatment, right, we see, lo and behold, very nice to see, we see patients who are not succeeding all of a sudden succeeding. Here's an adolescent patient. Remember, I think that this picture, that this call out is important. We want to remember this is approved down to age 12. So an adolescent patient achieving FAAD 90 at week 52 with Opzelura. So baseline week 24, 90% change. So is that the end? Is that as good as it gets? Nope. Nearly 100% repigmentation out at week 52. Again, making the point, it takes time. So now achievement of FAAD 50 during the 52-week treatment period. So holy cow, right? It makes a lot of sense, right? If we lower the bar for achievement, and so now we're not asking for an FAAD 90, not asking for an FAAD 75. Obviously, FAAD 90 hard to achieve, but we do it. But now FAAD 50, 75% of patients with Opzelura twice a day over a year achieving 50% improvement in baseline disease. And then here, just an example of a patient. And again, this one is particularly important. Look, week 24, 10% change, not a big change. 52 weeks, 60% improvement, actually inching towards an FAAD 75. So again, just highlighting there are myriad ways to respond. Some patients are going to be very slow, some are going to be more rapid, but in all cases, this is something that takes time. Now here, patients achieving T-VASI, so now total body VASI. So take the entirety of their vitiligo over their entire body, and now we're asking for a 75% improvement. Remember, on an earlier slide, we talked about density of hair follicles being directly related to responsiveness to treatment, face being an area of high density of hair follicles. That's why it does so well. Body, less so. And so we don't expect the same thing of body vitiligo as we do of facial vitiligo responsiveness. And so we're not surprised here to see lesser response, but again, 21% of subjects over a year. But again here, really important, if we do not describe this to patients, we're going to lose them, right? Because nobody walks out of our office and thinks in their head, oh, I'm going to need to do this for a year to win. I'm going to need to do this for a year to succeed. Come on, that's not how any of us think, unless we tell our patients that this is the case. And proportion of patients achieving T-VASI 50 at week 24. So again, just to be clear here, right? The last slide, we are looking at T-VASI 75 over 52 weeks. So now here, T-VASI 50 at week 24, 20%, 26% of patients, obviously, right? More patients than the stricter endpoint, 75% improvement, which is what we saw on the last slide. And then just some representative images of what this looks like. So baseline antecubital fossa, week 12, 20. I mean, there's some follicular repigmentation, and then week 24, we see that follicular repigmentation is all expanded. There's more sites of repigmentation, and we get to a 50% change. Chest, a lesion on the chest, again, boy, holy cow, right? Not much happening at week 12, week 24, a lot more. It does not look like the face. Really important, related to follicular density. But again, also just really fast, just remember the slide a couple back where I showed you T-VASI 75 over a year. Again, right, we see an upward going line. So again, 12 weeks for body in particular, very early. 24 weeks, still relatively early. 52 weeks, much better to achieve a higher bar of success on the body. And then here, again, just more images, but I really like the foot here, right? There's not a lot of change. You can see some change, but you don't expect it. Here again, counseling, critically important, right? If you take somebody with fingers and toes involvement and you say, oh yeah, sure, 20% of people have 75% repigmentation on their body over a year. Well, no, remember, we talked about, right? Fingertips, toes, no hair follicles. So we have to account for the lesions that the patient has, the sites of those lesions, and think about the data across the different body sites. This is, I actually really, I also love the elbow pictures because we don't necessarily expect a whole lot from elbows. Here, holy cow, 24 weeks, this person did great. So again, variability, but we have to set appropriate expectations. both for patients and ourselves, actually, right? If we don't account for these factors ourselves, then we too are not going to understand the results that we see. So now the percentage of subjects achieving T-VASI 50 during 52 weeks, right? So we saw the 24-week bar graphs, and so now what happens over 52 weeks? You know, we're not surprised, but again, just reinforcing this really important message and theme. This takes time, right? We have to take melanocytes that are in the melanocyte reservoir in hair follicles where there are no hair follicles, there's no melanocyte reservoir. We have to take them, we have to stop destruction of melanocytes. Then those cells need to leave the stem cell niche, go into vitiligo affected skin or depigmented skin, repopulate that skin, repigment that skin. This takes time. And again, I just love it. It's like we're watching biology. And like this is really, you know, if you think of this slide in a slightly different way, or all of these 52-week slides, we're watching biology. It's really kind of exciting. This isn't just data like, oh yeah, repigmentation to some degree over some period of time. No, we're watching biology. This is teaching us about how skin repigments. And then here, you know, look at the knee, right? Change in a small lesion is possible, but again, right, some sites just don't do as well. And then of course, look at the left knee. The left knee, holy cow, does really great. But again, we have to set expectations. So now treatment emergent adverse events. Wrapping up here, right? So we started with the disease. We talked about what affects people, right? A really important part of this. We talked about the mechanism of disease, why Opzelura sort of marries so nicely with that story as a JAK inhibitor, very directly interrupts disease pathogenesis. And now let's talk about adverse events. In the 24-week clinical trial, why do we talk about adverse events here? Because it was the vehicle-controlled period. So we see, you know, how common any of these events were in vehicle patients versus Opzelura treated patients, you know, and call your attention, you know, to the second to top line. Application site acne, 6% of Opzelura treated patients, right? Acne, right? We commonly see it on the face, commonly see it on the torso. Remember in this clinical trial, right, we're treating patients' faces for sure amongst the body site. But so we see acne 6% versus 1% with vehicle. Again, everybody on the call hopefully has awareness, JAK inhibitors and acne. Yeah, we're familiar with this. This is a familiar theme. Now the rate's not high, but again, if we don't look out for it, we're gonna miss it, and we don't want to miss it. Acne's in our wheelhouse. We know how to deal with this. Now here, 52 weeks, right? So we just looked at 24-week data, now 52-week data. Right, we see the two clinical trials, COVID-19, application site, acne. Okay, 6.3%, 6.6% over a year, right? So nice to see, right? We're not seeing increasing rates of acne with increasing time of exposure. We like that. Notice application site reactions, uncommon, low rate of application site pruritus, headache, 3.6, 6.1% of patients. Yeah. Actually, hang on, just one quickly. Patients with an adverse event leading to discontinuation, just notice that very low rate, right? 0.5%, 0.9% of patients. And now, how are we going to do this? So Opzelura, ruxolitinib, 1.5% cream, right? Comes in a 60-gram tube, and it's not a steroid. Really important to communicate, right? A lot of our patients with vitiligo, maybe all of them, have been given a topical steroid. I think it's important to communicate this is not a steroid. Whether or not you want to say, and you know, the mechanism of action of this medicine, the way it works, really kind of targets the pathophysiology of disease or not, remember that. I think it is nice to be able to communicate that with patients, because this isn't a blunt instrument, right? We're not just hammering inflammation with steroid, right? We're targeting pathophysiology with a topical JAK inhibitor. We can use it on the eyes. We can use it around. Not the eyes. We can use it on the eyelids. We can use it on the area around the mouth. We can use it on the genitalia, and obviously it's for topical use only. And again, really important, that message on the far right, twice daily application. Twice daily application. Really important, not once daily, twice daily application to up to 10% body surface area involvement. And just know that there is support for commercially insured patients. Right, it's great to have a medicine. It's not great to have a medicine if we can't get it to our patients. So just recognize that there are these programs in place to help our patients get the medicine that we want for them. And wrapping up, right, there's the box where we started with the box warning. We're ending with the box warning. Really important. The box warning is sort of, it's gotten as much excitement as there has been in the last few years about JAK inhibitors in dermatology. There's, been as much attention, which is fine, as much attention given to the box warning, the evolving box warning. And it's just really important, again, for us to recognize and give context to it. Serious infections. So again, right, we see in patients treated with oral JAK inhibitors, serious infections are possible with JAK inhibitors. And here, just look at the text. I actually take a second to read the text under mortality. It's a reference to a post-marketing safety study of an oral JAK inhibitor in patients 50 years of age and older with rheumatoid arthritis. Okay, so the box warning for Opzelura, a topical JAK inhibitor, refers to a study of an oral JAK inhibitor in patients 50 years of age and older with moderate to severe rheumatoid arthritis. Malignancies were reported in patients treated with Opzelura, and then again, see the reference to this other study of JAK inhibitors, oral JAK inhibitor in RA patients 50 years of age and older. Major adverse cardiovascular events, again, that same reference. Thrombosis, again, that same reference. And, laboratory abnormalities were reported at small rates, but again, they were reported. Lipid elevations been seen with oral ruxolitinib. So remember, this is topical ruxolitinib, with oral ruxolitinib that was seen and is seen with oral JAK inhibitors in general. And then pregnancy and lactation, right? Super important. There's a pregnancy registry, but we're not going to have pregnant patients or breastfeeding females using Opzelura for the treatment of their vitiligo. And wrapping up, we have the first and only FDA-approved topical JAK inhibitor for vitiligo. Really, really important to us. It really marks a change in a disease, a historic change in this disease. Again, think about this down to age 12. We see nearly 1 in 3 people in the clinical trials achieving a 75% improvement in their baseline facial vitiligo. We actually see 20% of patients over a year achieving 75% improvement in their body vitiligo. Again, it's a really high bar of achievement and calls out that this takes time. And so we have to change the way we think about this disease and its treatment, and we have to communicate that effectively with patients to help them achieve success. We talked about adverse reactions. We talked about why. Why are we doing this? This wasn't a chance observation. We're literally taking a medicine with a specific mechanism and marrying that with disease in a really beautiful way. And the efficacy shows that that concept was spot on. And it's not a steroid, which again, I think is another important point. Thank you so much for your attention. I think we've got about 10 minutes, and so we can take questions if there are any.
Absolutely. If you want to submit your questions, use the question chat pane on the right-hand side of your screen. And if you think of any questions after this event, you can always send them on info@idefeducationalseries.com. We'd like to thank again our supporter, Incyte, for making this educational event possible.
Thank you so much, Roxanne, and thank you, Dr. King. That was very, very informative, in very much detail. So thank you so much. We have a curious audience. We have a lot of questions, and we'll try to answer as many as possible within the allotted time. So one was, how long can you use Opzelura? Since you advised us that, it's not a short-term treatment. It's we have to advise our patients, handhold them, and keep patient. How long can we use it?
Yeah, it's really important to recognize that there's no limitation of its use in the label, and so we use it as long as we need it. And that really is it's a good question, and it's an important one again, right? Because in a way, somewhere deep down in our psyche, right, when we think to ask that question, we're thinking, oh geez, I've heard a lot about safety of JAK inhibitors, can I do this? Remember, this is a topical. It was used for very long periods of time in these clinical trials. Patients were monitored carefully, and so right, it's the importance of events like this is for us to see the data, see how clinical trials were done, look at the adverse effects table and say, oh geez, okay, we each make our own assessment and move forward, but there's no limitation.
Perfect. Next question is, can Opzelura be used with makeup or sunscreen or moisturizer for that matter?
Yeah. Again, a super important question, right? For a topical medicine, right? Again, there's no limitation. However, right? We have to think about, okay, so for somebody who does wear makeup, for somebody who does wear sunscreen, right? We're going to put it on first, right? Which obviously it almost makes sense, right? We're not going to put on makeup and then put a cream over it. But the answer is yes, but think carefully about order of application.
And what's the order should be?
Oh, Opzelura first.
Okay.
Opzelura first, and then whatever you're going to do after that is okay. And by the way, if anybody on the call has yet to open a sample and feel this vehicle, here I'm not speaking on behalf of Leon's organization or on behalf of Incyte. It's just do it, right? It just makes sense, right? You have to know what you're telling somebody to use and to do, right? They're putting this on their face. It's really important to us to know what this feels like. I think you'll be pleasantly surprised. It's almost more of a lotion, I think, than a cream.
Well, you know, vehicles matter, right, Brett?
Oh, totally. No. They matter for all kinds of things. But if anybody has not done that, do it tomorrow in clinic.
So we have a really interesting question, and this is a really good question. I don't know if you have the answer or not. So we saw in the study that there were a lot of patients with long-standing history of vitiligo. So the question asks, is there a difference between the patients who had short-term versus long-term in the efficacy, right? It's $1 million question. I don't know if you have an answer.
There's no difference. There's very little difference, and certainly not notable. And so, and that was the point that I made, or I tried to make earlier, was that the median disease episode across these two trials was, I think, 11 and 13 years, if I remember exactly. I think it was 11 and 13 years. That's the median. So half of patients were longer than that, half were shorter. And so this was not like patients, this was not a clinical trial of patients who had disease for a year and lo and behold, they get better. No. There's a lot of long-standing disease in this clinical trial, which I think is really important to us because we don't want, obviously, right? If it said not to use it in those people, we would want to know that. Nope, no limitation.
Now, another $1 million question. Once you have full repigmentation, do you continue the medication? If so, how long before stopping?
Another good question, boy. So here we do not have data, and hopefully we're going to have more data to guide us over time. But here, this is, I think about a phrase that I hear my wife, Britt Craiglow, a pediatric dermatologist, who Leon told me before the call is a much better speaker than I am, or at least draws much bigger crowds. So she likes to say, in dermatology, we're cooks in a kitchen. We really like to sort of like tinker and kind of, play with things. And, I think that's right. We're all going to approach this question differently. What I would do personally, I'm really big on patients not getting better and then just stopping what we're doing cold turkey. I really believe, and especially with a topical like this, right? You get to a patient to their goal, and then you say, why don't you for the next 4 months or for the next 6 months, not twice a day, try twice a day, every other day. Do that for 6 months and see if you hold. And if it holds, then we can go to twice a week to see if that holds. But again, we're gonna play with this to see what can be done, and I'm sure every patient's going to be different. But I think if we play with it, we'll figure it out. Some patients are going to need it to maintain. Other patients will be able to go to a decreased maintenance regimen.
So I think that's really your experience how you do it. Unfortunately, we don't have the data.
Oh, absolutely not. No, super important. Super important to recognize. We did that. That's just me offering up a possibility, but that's not based on data.
Yeah. Well, we are at the top of the hour. I thank you so much. That was very informative. We learned a lot about vitiligo. We learned a lot about Opzelura. Thank you so much, Brett. I really appreciate it. We thank you, our sponsor, Incyte, for this educational program. And I'm excited that we will have another educational program on December 1st with Dr. Andrew Alexis and Dr. Ama Alexis. So we're gonna have a couple program, dermatology and allergist. Thank you so much, and have a good night, and have a good Thanksgiving, everyone.
Bye-bye.
Good night, everybody. Happy Thanksgiving.
Bye.
Bye.